Life is complex, so is our mental health. It cannot be understood by diagnosis alone. Our philosophy is treat the person, not the mental illness. Hello everyone and welcome to another episode of Humanizing Mental Health. I'm Trent Nickers.
And I'm Jeremy Alcorn. Well, today we have a guest that is from the United States. This is actually our first guest that we've had that has come from the United States. This is Doctor Nicole OBarto-Trainer. So Nicole, welcome to the show.
Thank you.
So just to give a little bit of introduction, Nicole actually comes with a lot of really good knowledge. This is one of the reasons we're so eager to have this conversation.
Absolutely.
She received her doctorate in counseling psychology from West Virginia University and was clinically trained in the Department of Psychiatry at Allegheny General Hospital in Pittsburgh, Pennsylvania. She's also specialized in training in integration of mind-body therapies, the treatment of chronic gastrointestinal disorders and somatic disorders from the Allegheny Center for Digestive Health. Dr. Trainer has been studying integrative mental health since 2009 and has advanced training in mindfulness-based trainings, including things such as biofeedback, functional approaches to depression and anxiety, including nutrition, micronutrient therapy, and amino acid therapy. She's been in private practice since 2011 and founded Native, which is to bring about these integrative processes. Now, what we wanted to really talk about today, I think, is an overarching theory that fits with your kind of foundations of how you understand the human condition. And this is really coming more from a place of health rather than from a place of deficit. And so you're talking about holistic approaches and this innate theory of health. I'm super fascinated because this is new to me.
Yeah. So to start off with, I'm wondering if you could define innate health.
Yeah, so from my perspective, innate health is this idea that no matter what you've experienced or what you've gone through, that the natural propensity for mind and body is to always be moving back towards health. So it's this idea that our default setting is health, and that our systems are designed to alert us to disruptions in both emotional well-being and physical well-being, and that we need to kind of think about symptoms more as internal messaging from our innate health to whether it be physical symptoms or disruptions in emotional well-being, that these are things that we need to address, right? Like, and not just mask symptoms. When we just treat symptoms, then we just alleviate symptoms, but we don't really get to the underlying causes of those disruptions in the first place. Mm-hmm. And I think that really limits our ability to heal, both in the physical realm and in mental health.
Yeah, I love what you said there, because really what you're talking about, what really stood out to me is when you're looking at these, it's really taking it away from a problem-focused symptomology to how can we look at that and really work with our body, work with the messages, and really help to bring us back to a sense of homeostasis. Is that right?
Yes, that's correct. So I've spent some time studying Ayurvedic medicine, and I'm sure the two of you are familiar that Ayurvedic medicine suggests that, again, like our bodies are intrinsically sending us information, and that if we think about ourselves from an innate health perspective, it's this idea that if we pay attention to the symptoms that we're having, they're usually indicators of breakdown, mm-hmm. sometimes in the realms of physical health, but also in the realm of emotional well-being or mental health.
Yeah, this is fascinating. Recently I went through an experience that I think really connects with this. That is, one of my siblings became really, really ill, and actually functions internal organ functions were failing, and she was in the hospital, and it just looked like that this is going to be it. One of my other siblings actually stayed in the hospital room for like 2 weeks, didn't leave, and gave this additional care And basically you would say that my one sibling that was ill, my sister, she really leaned on the health or the nervous system of my other sister to help her get through that time. And she recovered and came out of the hospital.
Yeah, I love that because I often tell my clients that a part of my role as a collaborator in their therapy journey or healing journey with me is that I'm going to hold space for their health, right, until they're able to embrace embrace it a little bit more freely within themselves. So in the way that you described kind of your sibling kind of sharing that health energy with her sister at a time where maybe her sister wasn't as readily able to receive it for herself, to connect with her own innate health.
Totally. Indeed.
Yeah.
Yeah, I love that. I'm curious for you, like when you talk about holding space. So I wonder how that makes how you practice with your clients maybe unique or different from other therapeutic practices.
Well, I think one of the things is I'm not really listening to figure out what's wrong with them. I'm always listening to hear what's right with them. And when I do hear sentiments of their health, I try to draw attention to those and try to point those out, because I think we end up becoming conditioned to focus on our deficits, where we feel like we're not measuring up, where our human experience is not providing us with what we desire, where our emotional well-being is falling short of where we would like it to be. And so I think it's important as a collaborator from a health focus model to help my clients really connect with like where kind of like where their innate health is calling to them.
No, there is one thing that does jump out at me. Like you, in terms of the timeline that you're practicing, would have been like before, kind of early in the era of moving in this kind of philosophy. That you were an early adopter of this, I would say.
Yes, I was. In fact, I was in my doctoral program in the early 2000s, and I remember approaching my training director, asking him if he could help me find doctoral practicums with psychologists that thought this way, practiced this way, integrated complementary and alternative medicine into their treatment approaches. And he basically told me that I shouldn't talk about this with my peers or in the community, because there wasn't this isn't how people are thinking. And I needed to stick to learning the basic, kind of the basic constructs in psychology and psychological theories of mental illness. So yes, I would say I was an early adopter.
Yeah. So with that in mind, like I can kind of hear that bit of a rebel spirit in you. How did you go out and find these people to help you gain this knowledge? Like if you couldn't go about it in the traditional manner, I'm curious.
Yeah. So I guess it was pretty serendipitous how I was able to have my first experience with a provider who thought in this way. And her name was Dr. Linda Pettit. And she was a psychologist, and she was practicing in Morgantown, West Virginia, and I was in my doctoral program at West Virginia University. And she really took me into her practice, and she introduced me to the theory of innate health by Sydney Banks. And Sydney's theory really aligned with what I had already believed in my heart, what I already thought was the way in which I wanted to practice and interact with my clients. And so what I like to think about that experience is it gave me like an initial language for talking about health-based approaches to mental illness.
Mm-hmm.
So it was a really profoundly positive experience that I had with Dr. Pettit. In fact, I oftentimes think I need to circle back around and connect with her and thank her again, because she really did send me on a trajectory for my career and for my client work that's been really rewarding, because I continue to integrate the principles that I learned from Sydney Banks' theory of innate health into, it's kind of like the foundation of my therapy work.
Mm-hmm. You know, it's interesting because I can join with you in terms of a little bit of that sense of rejecting the disease-based model. I remember in grad studies when I was doing my oral defense that there had to be an external on that panel, and this was someone from nursing. And so I was looking at depression from a lens of complex systems theory, and so then the interplay between person and environment. And then the nurse at the end said, "I just have one question for you, and that is, can you move this into any other framework in your mind?" Like she was talking about the notion of chemical imbalance as a causation for depression, and I said, "No." Was that simple of an answer? No.
Wow, I can, like just as the two of you talk, I can really see the commonality between the two of you. And I wonder, Nicole, what it's like for you having this model, and I can really hear the passion for you. Like, what was it like learning this and then having to interact with professors or with other students that were more focused on the disease model? And how have you really carried this forward and maybe shared or interacted with them?
Yeah, so I definitely felt accepted by my peers. I think that people were fascinated by like what I was interested in, right? So the language, I relied heavily on back then would have been like integrative or complementary and alternative medicine. That kind of helped it provided, I guess, a common language that we could use, even though I was also talking, I think, like more philosophically about how I was going to approach caring for my clients, right? So like I'm intentional about using the wording disruptions in emotional well-being in lieu of mental illness, because I believe that we need to develop language for understanding that disruptions in emotional well-being should be considered a common occurrence within the context of the human experience. And that if we develop this over-pathologized language of thinking about mental illness, then we're going to just cultivate and create more and more mental illness.
Wow, so, that's like right on our website.
Yeah, absolutely. I don't know. I had like thinking that either A, she was reading from our website, or B, I was sitting down and talking to the female Gabor Mate there for a second.
Yeah, for sure. Yeah. In fact, just that overlap, it's like this parallel process that's happening. And I think there's synergy that happens there, that often we see concepts developing in different places and they join together. Now, I got a question for you. How does this actually inform your treatment sessions? Like, what is it like for the client in the appointment?
Yeah, so, well, I usually start by providing, following a traditional biopsychosocial assessment, right? So I believe that the intersection between like the theory of innate health and biopsychosocial approaches to treating disruptions in emotional well-being is this idea that we have to take into consideration the whole person, right? So I think a lot of, Ayurvedic medicine, functional medicine, Chinese medicine, it looks at the whole person, how the systems interact with one another. So I do a traditional biopsychosocial assessment. Now, oftentimes for clients who've had therapy before, that's a really unique conversation, just because I dive into things like nutrition and movement and spirituality and gastrointestinal health, right? And some of these areas are not touched on in traditional psychological assessments. And then I usually follow that up by providing a great deal of psychoeducation around the theory of innate health. And I explain to my clients that the theory of innate health is going to kind of be the foundation of this house that we're building, right? So this house, this idea that sustaining emotional well-being throughout one's lifetime takes a certain amount of practice, right? In the same way that we wouldn't expect our physical health to sustain itself indefinitely without attending to it, caring for our bodies, sleeping, taking in good nutrition, moving our bodies, we really shouldn't set ourselves up to believe that our emotional well-being will just take care of itself if we don't do anything to help it along, right? Especially in the age that we're living in, with basically how our nervous system is just being bombarded constantly, right? We just really weren't built for this pace of living, and for the amount of like chronic stress that our system is under.
Totally.
But anyway, I think I kind of like veered off there a little bit. So I do provide the foundational theory, the theory of innate health, and then that theory provides probably like the cognitive lens that we really work from. So reframing a lot of cognitions. There's 3 principles within the theory: mind, consciousness, and thought, that we try to like begin to incorporate into the individual's cognitive experience. And then we do a lot of trying to understand like where there may be disruptions within like the physical body. So I provide a lot of education around how the body makes serotonin, what micronutrients the body needs to make serotonin, for example, dopamine, norepinephrine, all of the vital neurochemicals, right, that we rely on for balance, mood, and emotionality. So we work on that. We kind of, through kind of interpreting lifestyle, like my client's lifestyle, I'll offer up different suggestions of interventions that I might want them to try, whether they're movement interventions, whether they're nutritional interventions, lifestyle interventions, incorporating like mindfulness or some type of self-care practice from the mind-body realm into their life. So I really try to give like a very holistic, integrating all the systems into my treatment planning and into our approach.
Wow. One of the things that really jumps out to me is one of the things we know from the research from Miller and Duncan is that if you can line up with someone in terms of their theory of change, then outcomes become good. But one of the things I noticed is that often the person's theory of the problem actually doesn't work very well. And so their theory of change is going to get them nowhere. And it sounds like what you've really done there is help them to redefine what the problem is so that it gives them a different target to shoot at.
Yeah.
And as you've been talking too, I'm almost thinking to myself, like, how would this work for if you're engaging with an individual, like with the family system, and or even with couples work too? Because you're speaking with somebody about like their individual health, and I'm thinking about looking at if, for example, if there's a couple, how would you engage both of them? Would this be something that you would work on a couple's lens with, or even with kids? Sorry, I know that's all over the place.
Yeah. Well, I don't do a lot of couples work in my practice, but I think that it would make sense if you had a couple who was wanting to improve their relationship, that both of those individuals had an idea of their own like emotional well-being, right? And sought to address their emotional well-being on an individual basis. As far as working with kids, I do a lot of work with children and adolescents, especially because of when you take like a functional lens of looking at behavioral disorders, attention deficit disorder, emotion dysregulation, even subclinical attention deficit disorder, right? Like there's a lot of opportunity to reduce symptoms in kids who are just, kind of borderline ADHD, or there's a little bit of emotion dysregulation going on that's kind of disrupting the family system. But I do a lot of work with kids, and that's all family work, right? Like when we're talking about changing a kid's diet, when you're talking about applying a theory of innate health to kids, it's basically teaching parents how to see their child through a lens of innate health, right? How to recognize that when kids feel good, they behave good, right? And that seeing those disruptions, seeing those symptoms, once again, not as just a checklist in order to provide a diagnosis, but instead seeing those symptoms as that child's innate health way of saying, like, stop, we've got to pay attention to something that's going on here. Either my body is loaded with inflammation, my body and brain are loaded with inflammation, and that's why you're getting all this emotional reactivity out of me, or all this emotion dysregulation. I have such a severe food sensitivity that basically it's become toxic in my system. And so I'm acting out in this way, not because I'm a broken child, but because there's dysfunction in my system that I need someone to pay attention to.
Mm-hmm. Yeah, totally. Yeah.
Yeah. So absolutely, when I think about working with a family, parents have to be a part of the process.
Yeah, for sure. Like, it just reminds me of things that we know now about attention deficit disorder that are not just the checklist. The sensitivities are so high, not just emotional, but allergies, all sorts of other things, for sure. And seeing that from that broader lens makes sense. Now, I want to bring you back to a specific point you made before, and I think I marked this correctly in my brain. You talked about three things. You talked about mind, consciousness, and thought. Can you speak more to the pieces inside there?
Yeah. So within Sydney Banks's theory of innate health, he proposed 3 principles for sustaining emotional well-being throughout the lifetime. And those were mind, consciousness, and thought. And I obviously provide definitions of each of those principles to my clients and then educate them on how I'm going to ask them to try to use them to reshape the framework in which they experience their reality. And so the definition that I use, right, which is a derivative of Sydney's books and the time I spent with Dr. Pettit and just time now teaching this, right, is I often define for mind for my clients is like universal intelligence or the energy of all beings. If I have somebody that is particularly religiously aligned, I might say that when I talk about mind or when you read about mind, it might feel like your interpretation of the form of God that you've been taught. But the theory is not a religious theory. It does have some like spiritual underpinnings, but I believe it's a theory for all, right? But so we talk about mind as universal intelligence, the intelligence of all beings, the energy that connects all of us. So when you talk about your siblings rather, spending time, like I believe that's that transfer of energy, right, is a component of mind between each of their bodies, right, and how one nervous system is able to support another nervous system. So universal intelligence, mind. Thought is, we talk about thought as being formless energy, so that it's transient and neutral, meaning that it's important that my clients know that they are not their thoughts.
Mm-hmm.
So I teach them about kind of the separateness from thought, and that thought in and of itself has neutral energy tone. It's not until we breathe life into our thoughts using the gift of consciousness and assign it with emotional value that thought then has kind of emotional tone, like an emotional tone. So I often teach my clients that their feelings are just a measure of the quality of their thinking. And then we talk about consciousness. Like consciousness, we're partnering consciousness and thought all the time to experience our reality. So in this way, we're using mind, universal intelligence. So it encompasses all energy, all formless energy of thought. And we're partnering thought and consciousness to create our reality all the time. And then at an individual level, each of us have mindsets, right? Or we might think of them as like outlooks or perceptions. And I like to teach my clients that those mindsets are like a smaller collection of that universal intelligence source. Their mindsets are a smaller collection of thoughts that they're often using over and over and over and over again.
Mm-hmm. Yeah. Wow. I'm sitting here trying to process all of this. I can see or I can understand some connections there, but I wonder. Like I'm just thinking to myself, like where it's the larger universal mind, and then really tapping into that and saying to, like if I was one of your clients, I can imagine that idea of, okay, how am I tapping into that energy? What energy am I pulling from there, and how am I utilizing that? And then how can I shift that as a way to support my overall health. Am I understanding you correctly?
Yes, absolutely. Absolutely. Like, so essentially it's teaching clients that what you're experiencing as your reality, or what you're experiencing as your life, is exactly what you're expecting to experience.
Mm-hmm.
So that we're always getting kind of exactly what we expect.
Yeah, one of the things that really jumps out at me is it sounds like a deprogramming of what people already believe about what their health is, and an attempt to overwrite that programming with something that will allow them to heal.
Yeah, I think that's a great way of describing it, because I'm oftentimes talking to my clients about how we end up setting up this default system, this default relationship with mind and thought, that we're much more in relationship with the things that we're afraid of, or that we're trying to avoid experiencing, than we are in relationship to the energy, or the thoughts, if you will, of what we're trying to experience.
Yeah, and I could really see this overlapping with multiple things, with what we've referred to often, Daniel Siegel's interpersonal neurobiology, and also with things that we talk about. We had the Chinese medicine doctor that we have here came on and was speaking about this, and the notion of the flow of qi. There's just, I can see why you would connect with all of these things, because of and how much that would have resonated with you. I imagine you use these concepts in your own life.
Yes. Yeah.
I have another question. As a social worker, I'm always interested in the broader social system, and so I'm curious. How does the process of, like, the diagnostic manual? Of course, it has codes for a reason. I often say to people, the reason this book exists is because insurance companies exist. Now, in Canada, it's not exactly the same. That is, lots of people don't need a doctor's note. They don't need anything to access their insurance. You don't need a diagnosis to be able to do that. But I'm curious, within the way you work and within the broader system, how does that fit into your practice with the required, diagnostic process to gain access to people's funding?
Yeah, so probably a little dissimilar to your clients, because my clients need to, in order for them to use their health insurance for services, I have to give them a diagnosis. So I am working within the framework of the DSM and identifying, a diagnosis for my clients in order for them to access the care that they want to be able to receive. But it's not the, I guess it's not the emphasis of the work, right? They're informed consumers of counseling services, and they're informed of my conceptualization of the collection of symptoms that they are identifying, and how that translates to a particular diagnosis based upon the system that we're operating in.
Yeah.
But it doesn't become like a large ongoing talking point within the work.
Totally.
Yeah.
Now I'm wondering, what does that do for you? Like, here you are working within a system that requires a disease focus, and somehow that maybe causes some, disconnection for yourself. I'm wondering about that.
Yeah, I guess, we have to work with the system that we have. So I think, in the time that I've been practicing, like, the availability of mental health benefits for clients has come a really, really long way. And I want people to be able to use their health insurance. Yeah. And so if I have to key my conversation with them up to be able to support ethically giving them a diagnosis in order to be able to use their health insurance, and then just kind of backing away from that diagnosis slowly and really recognizing that these symptoms are really just your innate health way of getting your attention, right? Like, the part of you that is kind of crying out to heal and to be seen and be heard and to function, differently in your life, kind of needs these symptoms in order to get your attention.
Yeah, and I wonder if if this experience might kind of fit with what you're talking about. When I was working for Alberta Health Services, part of the public health system, then for individuals to be able to get care, we had to do a provisional diagnosis. Often, I just put down things that were the least intrusive, so that some other point in their life they're getting insurance and they're getting life insurance, and they're like, oh, well, you've been diagnosed with a major depressive disorder 3 or 4 times. We're kind of worried about maybe the policy prices go up or whatever. So I'd usually try to slide in something like an adjustment disorder with depressed mood. So certainly I could see where you're coming from with that. The only thing that I think becomes very difficult is when they don't actually fit a diagnosis, but they actually need help.
Yeah. How do you get them to give them that key to the system where, there's not that perfect key that fits?
Yeah. I mean, there's so many disorders that probably there's overlap enough that you can find something that would be appropriate to say and for it to still be true. But
yeah. So, I mean, I'm very conservative in my diagnosing. Like you say, I rely a lot on adjustment disorders with mixed disturbances in mood and emotion, because I do think about like the longer term implications of any diagnosis for my client. But I think that those of us who are practicing, if we were all as honest as we could possibly be, we are treating a lot of people in our individual offices, probably both throughout the United States and in Canada and everywhere else that's acknowledging and treating mental health concerns. We're treating a lot of subclinical disruptions in emotional well-being.
Yeah,
right?
Absolutely.
But I feel like I put some of that responsibility back on the healthcare system itself, and the absence of preventative models and benefits that are designed with the intention and the idea that if we prevent a major depressive episode, we have saved the insurance company and the healthcare system so much more money, right, than they ended up having to pay for, for 12 to 18 sessions of psychotherapy.
Right. Yeah. One of the things I have seen, and I'm wondering if it's similar in where you're practicing, is that a lot of the insurance companies are actually making their the packages much bigger. I've seen from Veterans Affairs here, where veterans have just got a call from their caseworker saying, we're just checking in on you, finding out how you're doing, identifying concerns, referring them into services immediately. There seems to be a much bigger movement in our society around appropriately addressing mental health concerns. Did you see that as well? Yeah, and this is why I think one of the things that's so important we have this conversation is because while there's this emphasis, we got to make sure that people know that the disorder or the diagnosis is not the problem. That's just a description of what someone's experiencing. And that's why I think this conversation is so important, is that a lot of people just identify so much with that label. Like when Asperger's came out of the diagnostic manual, what about those people that for 20 years of their life had that label and they're like, I've accepted this is who I am.
That's who I am. That's part of my identity.
Yeah.
I don't know what they would do, like if they came up to me and said, "You no longer have cerebral palsy." I'd be like, "No. I have cerebral palsy. This is me."
Mm-hmm. Yeah.
And I think it's fair to say that sometimes our clients feel a sense of relief when we can help put a name to a collection of symptoms that they've been experiencing for a period of time that they haven't otherwise really understood why they were experiencing that. I think that can be very normalizing as well.
Yeah, for sure. It is that double-edged sword, isn't it? Like often when I would go through an adult screener for attention deficit disorder with someone after I've heard their story and I'm pretty sure that this is something that's going on, I would usually follow that up with I don't even see this actually as a disease. This is just a certain way that a brain has developed within its environment. And then I usually ask them to read the book Scattered Minds. That helps them to be able to find more broader healing in their life.
Yes. Yeah.
You know, as we talk about this, one thing that pops into my head, and I always think of the lens of a client's individual culture. And for yourself, Nicole, do you find with some clients that you're treating with individual culture, when you're presenting these ideas to them, that they have an either greater or more difficult time latching on to them in some ways?
Well, I think that it's important to adopt kind of a cultural lens to see, in order to be able to interpret or take up like any of these theories that I might present or that may be available to us, right, within the larger psychological theory, right, context. So I talk with my clients about, it's like a very conversational conversation, right? Like where I'm saying, like, how does this, resonate with you? Have you been introduced to any ideas like this before? Does this sound like something else that you've heard, right? And oftentimes they really guide and inform me, like, well, it sounds like what you're saying, like I was introduced to this idea by my family, or, I was introduced like this, my culture believes this, or I have this particular spiritual practice that kind of lines with what you're saying. So I really do try to kind of present the theory of innate health as like a starting point or a foundation that we're going to build upon based upon like the lens in which they see, the lens in which they're informed, right? Like they're influenced by their family system or their larger culture.
Sure. And one of the things that does jump out at me is as you talk about this in terms of culture, but in terms of in general with people as well, and that is when you start to ask them to do things like, I want you to take this particular micronutrient, or I want you to eat these particular kinds of food, or whatever the intervention is, it doesn't come out of the blue. They have a foundation of understanding, okay, this is why this person wants me to do this, and they can, I guess, more fully invest in it rather than just brushing it off. Because what does compliance processes look like for you? Are people actually following through with guidance?
Yeah, so I'm in a small outpatient clinic, a lot of commercially insured clients. And so there's a lot of self-motivation. There's a lot of self-selecting into seeing a provider like myself. So maybe there's somebody who's been on antidepressants for many years and they want to get off, but they're afraid. They need somebody to kind of help mentor them through that process. Or there's, an adult that has had undiagnosed attention deficit disorder and they're not wanting to use stimulant medication, but they are looking to improve their processes. And so they're wanting some support in that regard, or chronic stress. So, most of the time self-selecting in high level of motivation, high level of desire to learn from me and to collaborate with me in order to improve their overall human experience.
So from that like trans-theoretical model of change, you're seeing people that are beyond pre-contemplative, they're at least contemplative or more likely into kind of preparation by the time they get to see you?
Yes, yeah.
I'm curious if clinicians or if the general public is just interested in learning more about this. Are there resources or books, because I'm a big reader, that you would suggest that people look into?
It's time for a shameless plug. Tell us about your resources.
Yeah, absolutely.
So I think this is a part of my joining this call with you today is a part of me trying to take some of my experience and give it to more than just one person every hour in my office. So I mentioned Sydney Banks and the theory of innate health, and there certainly are, lots of other health-based theories that are starting to, be talked about and published. But I don't really have any shameless plug of myself. Really.
Oh, wait, yes, of course you do. First of all, where are you located?
Yeah.
How do people get a hold of you?
Yeah. website, email address.
Yeah, we'll end up putting this into the show notes as well. We'll put your information in. We'll put your website in. But we do have listeners actually from all over the world. Yeah. And so I think knowing what it is that you can provide for people locally, because there are different rules for that. Like I can't see anyone outside of Alberta for telehealth. So like if you could give us some of that contact info.
Yeah, sure. Okay, so I'm licensed in the state of Pennsylvania and West Virginia in the United States. And so I am able to provide telehealth services throughout both of those states. I provide in-person therapy in Western Pennsylvania. Like I'm in Latrobe, Pennsylvania, which is east of Pittsburgh, Pennsylvania. I'm about 35 miles east of Pittsburgh. And my organization is called Native. And my website is nativeclinics.com. And I could give you my email address too, if that would be helpful.
Go ahead.
Yeah, absolutely.
So it's just Nicole Trainer, Nicole.Trainer at nativeclinics.com.
Perfect. So if people have questions or they want to be able to connect. Now, I also want to give a bit of a moment here to just identify if there's anything that either in our conversation or that has come up or things that you really have felt like you want to make sure are represented that maybe we haven't got to today.
No, I really think that I was really attracted to like your podcast because I think it's really important that we continue to have conversations about humanizing mental health, right? Like not just focusing on identifying mental illnesses, but really recognizing, as I said earlier, that like disruptions in emotional well-being are a normal part of the human experience, and we have to learn how to manage our emotional well-being in the same way that we're taught very young how to manage our physical health. I think that we see these epidemic levels of depression and anxiety in young people, and it concerns me that we're giving them a lot of pathology-driven language in which to think about their emotional well-being. And I worry that we're not simultaneously giving them enough health-based language, right? Like that we're taking experiences that once we would have considered kind of normal rites of passage, right? To struggle a little bit socially or feel a little bit nervous about public speaking or feel a little bit of anxiety about an upcoming like sporting event that we're involved in. And we're labeling those emotions that we're feeling in a pathological way. So I have always been really passionate about reduce the stigma, like raise mental health awareness. And I love that post-pandemic, there's been so much more energy around understanding emotional well-being, and so many more resources have come online and available to us. And we certainly, I think, are reducing the stigma around psychotherapy and seeking therapy. But now I feel like we have to pump the brakes a little bit and build a little bit of a little bit of curriculum around how do we inform young people about the ever-changing landscape of their emotional well-being. How do we have conversations with young people about the developmental context in which their emotional well-being exists, right, throughout the very tumultuous years of adolescence. So I think that's probably the one thing that, I think continues to come up for me when I think about humanizing mental health and focusing more on health-based language and non-pathological ways of talking about emotional well-being.
Yeah, and I really love that you really highlighted, and I think that this is something that I've talked to a lot of people about, where it's healthy depression, healthy anxiety, and that little bit of pressure or struggle that can really form resilience, where we don't want to bubble wrap our kids, I'm sorry if that's a little bit of a trite saying, and it even brings me back to, I was listening to CBC News, and they were talking about with kids now, where they're trying to encourage them to do more rough play, go outside, do things, get a little bit dirty. And I think with that, that speaks to really what you're saying, that they need those moments where they have struggle, and then they can go back to their attachment figure and process that when need be and build that up. So when they do come up to the larger feelings of anxiety and depression, and if that is clinical, then their barometer is set properly. Is that correct?
Absolutely, yes. I love that way of thinking about it, right? Like the idea of going back to an attachment figure and processing and setting up the barometer appropriately. Yeah.
For sure. Like I've said this many times before, the same sort of thing that you're talking about. It feels so good to hear someone else say it. That, yeah, we want to destigmatize mental health. We don't want to pathologize our whole human experience at the same time. Mm-hmm. That people like, oh, no, you know what? I have depression. Because of my depression, I can't do this. It's like, well, that's not actually true. Almost everybody that has a depressive disorder gets better. Like, we know that. Mm-hmm. So.
Yeah, it comes back to that old saying of what we resist persists, rather than pushing away our anxiety, our depression. Let's engage with it. Let's talk about it. And, if need be, let's bring it along with us.
Absolutely. I encourage my clients to incorporate the mindfulness skill of curiosity into their understanding of their emotional well-being, right? Like, how can I be curious about my symptoms? How can I be curious about how I'm feeling, right? And just to, kind of follow up with something you were saying, Jeremy, also, we know that most people with depression get better, right? But we also know that if we don't provide them with a lens in which to sustain their emotional well-being, then we send them out just waiting for a relapse. Mm-hmm. Right? So we have to, again, I think it's that, what is the default setting? The default setting is health. The emotional well-being is something that we are all capable of. And if we establish mindsets that are tuned for establishing a relationship with a collection of thoughts that allows us to experience our innate health, right? We're more likely to sustain that.
Mm-hmm. Yeah. In fact, that sounds like a beautiful note to wrap things up on, doesn't it?
Absolutely, yeah. And like, as we were sitting here, I'm trying to think to myself, okay, what are my takeaways from today? I'm like, do we have 15 minutes for me to just talk about everything? But the one thing that really stands out for me today, and I think it's something that you reminded me of when you were talking about, what energy are we really attuned to, where we're more drawn to the negative energy and pulling that in subconsciously, or that we're not really aware, even though that we're wanting the positive. And I think that that's something for myself, that's something that I often forget.
Yeah, and actually for me, of everything we talked about, the thing that I went, deficiency in myself, is probably how I relate to food. And what am I choosing to put in my body, as you discussed how all of these things connect together. And that's something I'm probably going to really take a look at here. Mm-hmm. Yeah. So on that note, thanks again for joining us, Nicole.
Yeah. Thank you very much. I'm Trent Akers.
And I'm Jeremy Alcorn.
See you next time.
Thank you for joining us today. We hope that this message has been as meaningful to you as it has been to us. If you're looking for help, you can find us on Facebook at Humanizing Mental Health.